Welcome back. In the last lecture, we discussed myopia. Today, I will talk on hypermetropia. Like myopia, anatomically, hypermetropia is also divided into three types. One is the axial hypermetropia, in which the axial length is short as compared to the normal. One is the curvature hypermetropia, in which the curvature of the cornea is less steep, that is more flat, unlike myopia in which it is more steeper, it is flatter. So it is curvature hypermetropia. And the third one is also the same, index hypermetropia, in which cataractous changes occur in the crystalline lens of the eye. So these are the anatomical and some pathological causes of classification of hypermetropia. Besides this, I will discuss the classification of hypermetropia, which is being asked in the exam, keeping in mind that my audience is fourth year undergraduate students or general practitioners. I will also tell you that classification, which is very important, not only to pass in the exam, but to understand actually what does hypermetropia do to your eyes, and it will give you a glimpse of how to dispense the glasses, whether in myopic number or hypermetropic number, keeping in mind the one single thing you should keep in mind while prescribing any type of glasses, that accommodation of the eye should be at rest in any case. So, in hypermetropia, again, in emetropia, what is emetropia? Emetropia is that when the rays of light are coming from the infinity, they form a single pointed focused image on the retina when the accommodation is at rest. This is the definition of emetropia. In myopia, the rays of light are focused in front of the in front of the retina, causing myopia, and in hypermetropia, they form an image behind the retina. So, hypermetropia, uh, hypermetropic patient will come to you with the complaints of difficulty in visualizing the far vision and the near vision also. Usually the near vision, because in myopia the patient can easily see the near vision and the far vision is disturbed. Here, a myth is there which I want to clarify, that it is not necessary that myopia is nearsightedness, so patient cannot uh, visualize, can only visualize the near vision. Even if even if the patient is hypermetrop of very high level, for example 4 diopter, 6 diopter, or 10 diopter, he may not be able to see the near vision because his accommodation is beyond the capacity to accommodate for that plus 10 diopter. So even the hypermetropic patient can come to you with a complaint of decrease in near vision. But by and large, usually the patient comes to you with the complaint of near vision, and the far vision they are comfortable. Uh, Hypermetropia is further subdivided into two main types. One is the uh, manifested hypermetropia, in which patient wears the glasses, otherwise he will not be able to see clearly. The other one is the latent hypermetropia, which is a masked one, and it is further subdivided into two main parts. One is facultative and the other is absolute. I will try to share my screen, and I will I will try so that so that you people you people are in a better position of understanding what does it mean. So here I have opened the paint, and say This is retina, and in retina the rays of light are focused behind the retina like this. In myopia they are focused in front of the retina. This is hypermetropia. Now I will come to the two types. One is the manifested hypermetropia and one is the latent. Manifested hypermetropia is the same as I told you. The latent hypermetropia is further subdivided into two categories. One is the facultative hypermetropia. Say this is the facultative hypermetropia. The image should be formed here on the retina, but it is forming behind the retina. So, what will happen in facultative hypermetropia uh, is that the patient will accommodate, his lens will become more globular, its power will increase, and what will happen? This image will be brought in front of the retina here with the help of accommodation. So this is facultative hypermetropia. Facultative hypermetropia. Okay. Now, how it happens? When the person sees at an object and he is relatively young and he has got the refractive error of +1 or +2, he unconsciously accommodates and brings this image on the retina. How and this is the inherent tone of the ciliary muscle, which causes the patient to bring the image on the retina, and patient may not be able to know that he is accommodating. The usual complaint of the patient besides blurring of the vision is that the patient may say that he is having headache or asthenopia. That is, asthenopia means some unrest in the eyes. Well, this was facultative hypermetropia, and now what is absolute hypermetropia? Absolute hypermetropia is the one which cannot be corrected by patient's ability to accommodate. That is, if this is the absolute hypermetropia, patient may accommodate and bring the image right over here. But even then it is not on the retina. So by using all his accommodation reserves and all the things, he is still hypermetropic. So it is absolute hypermetropia beyond the capacity of the patient to accommodate. In these cases, we will have to prescribe some. We, in other words, we in these cases we will have to help the patient from outside, and there are methods by which the hypermetropia is corrected. There are some other factors also regarding hypermetropia which I will discuss. Um, I hope with these diagrams you are relatively clear. Now, there are two, three things which are to be understood. They are a little bit confused. One is that when you ask the patient to read from the Snellen chart, he cannot read, and his age is above 12 years of age. As I told you in the previous lecture, you will perform spinal test. It will exclude any organic disease. Then you will perform his retinoscopy, or you will do his autorefractometer to calculate his refractive error. In myopia, it is in minus or concave lenses. In hypermetropia, it is in plus or convex lenses, and they are usually in black color. And the minus glasses and concave trial frames lenses are usually in red color. These are very small points but very important, because in exam you may have to pick not just by color, and that this is this is convex or this is concave lens. These are very small but very important points from my point of view. Next thing is that when when you have evaluated and you prescribe the glasses, uh, there are uh, three options again. How you treat the hypermetropia? Again, like myopia number one. Number one and the most safe method is the glasses. You will prescribe the glasses, but not like the reading which comes on the hypermetropia. I told you just a few seconds ago that if the patient is above 12 years of age, there is a lot of information in this line. Why I used this word, this sentence? Because the older patients, usually more than 12 years, but it's not the very hard and fast rule, they usually do not accommodate. And the uh, refraction with the retinoscope or autorefractometer gives the correct number, and we take an objective reading, and we use the trial frame, and we do the subjective refraction, and that's it. If the patient is a child or less than 12 years of age, there is a very much chance that he will accommodate. It is called instrumental accommodation. That is when you will ask the patient to sit on the autorefractometer. He will see the object, but he will not be able to relax his accommodation. So we use cycloplegia. We give the patient atropine 1% eye drops, TDS for 3 days, and ask him to come back, and then he is in total cycloplegia, and we will come to know both the latent and manifested hypermetropia, and we will have the total amount of hypermetropia. Ideally speaking, unfortunately, in our setup, due to certain factors, we cannot practice this thing routinely, which should be done. Ideally, every patient, regardless of his age, he should be refracted with total cycloplegia. Anyways, we have uh, emerged a relatively deadline of 12 years. Um, when the patient is 12 year, okay, we have done cycloplegia and we have got the objective reading. Now, whatever the age of the patient is, we have got some reading. Now we will do the subjective correction on the Snellen chart, and we will make him comfortable to read the last most line 6 by 6, keeping in mind that he is not overcorrected. So because if he is overcorrected, image will again form behind the retina, and he will constantly accommodate and will have complaint of asthenopia. And we will slightly undercorrect, slightly we will totally correct the hypermetropia, or we will slightly undercorrect the slightly overcorrect the hypermetropia. That is, in other words, it will be convenient for us and the patient that the rays of light of hypermetropic patients are made to form an image in front of the retina. So accommodation is at rest, so he will not be have any problem. This will be the subjective refraction. It is also a separate subject, and in myopia, in the meantime, we usually undercorrect. That is, the rays of light are formed in front of the retina for the same reason. That is, the patient does not accommodate. In hypermetropia, also we either fully correct, that is on the retina, or slightly overcorrect, slightly make it myopic, so that he again does not accommodate and he does not have stains on eyes, asthenopia, and headaches, and like these. Now I'm coming to the conclusion. What are the options of correction of hypermetropia? Like myopia, there are three options. Number one, glasses, and the glasses are of convex lens as opposed to myopia, in which we used to give concave lenses. Number two option is contact lenses like hypermetropia, and number three again is refractive surgery. Refractive surgery again consists of the latest technologies, femtoLASIK and examined laser, also to some extent corrects the hypermetropia, but both with the refractive surgery, which is an irreversible procedure, you can have some side effects of overcorrection and undercorrection, and very rarely a disastrous complication of corneal ulcer or keratitis, and you may even lose the eye. The same holds true for the contact lenses, which you change daily, and the liquid can be contaminated. You can have recurrent corneal ulcers, and you can lose the eye either. So the best option are the glasses, and this was my lecture on hypermetropia. I was also thinking to talk about astigmatism, but because of the shortage of time at this time, uh, I will make another lecture in a day or a couple of days, and I will talk on astigmatism in a manner that you people may be able to understand and remember it very easily. Thank you very much. Please subscribe to my channel, give your feedback openly so that I may improve my way of presentation, my other uh, mm, issues which you feel should be addressed. I will try to improve it. The intention is to make you people learn ophthalmology in a very comfortable way. So I will be very happy to have your feedback. Goodbye.